this is new to me, and this is so far beyond what I've heard previously, because you've actually got data showing how the patient's jaw moves, and you can demonstrate a difference in movement when the patient's in provisionals versus when they're in their definitive restoration. Yeah, this is podcast number 3 that I'm recording, and I am very honored to have Riaz Yar, who's a specialist prosthodontist, joining me today. And we are going to be talking with regards to occlusion and implants. Now, Riaz, we've bumped into each other a number of times on conferences, but we've never actually sat and got to know each other better. So this will be an interesting conversation. Yes. If I understand correctly, you examine for the Royal College of Surgeons, and you've been head of MSc programs and things along those lines as well, haven't you? So could you just tell everybody a little bit more about your background, so they know the quality of what we'll be getting today?
I suppose from an overview perspective, I learn better when I'm being assessed. So what sort of motivates me is having a sort of structured way of learning. So I've done a lot of exams over the years, both from a specialist perspective. So I've got my monospec in pros. I've done a master's in soft tissue around implants and teeth with Zucchelli. Done other sort of research. So did my MPhil and currently doing a PhD at the moment. So I've always sort of had an interest in both research and learning. So that's sort of a brief overview. That's sort of my 20-year career in a sort of nutshell. Now, the key for me has always been, how you implement what you learn, because it's easy to read a paper, but it's sort of, can you apply it?
Yeah, I mean, I think in that context, we're quite similar, because I like to study hard, and for me, having some sort of structured learning is really good as well. So, in fact, it was Rudy who said to me, he said, "Pav, you've done 2 podcasts, not even introduced yourself." So I'm going to do a very brief introduction to myself as well. So I qualified in 2002. I've done a lot of training in different areas. I went over to America quite a lot to do a lot of Frank Spears courses. I've done Mike Wise's course. I've done a lot of other restorative courses, and it was about 2009 that I started to get into implants just a little bit, and then that's when I developed a passion for it, and I started to learn more and ended up doing my MClin in implants as well. So I've had quite a varied background, heavily on restorative, and then moving on to the implant side. And I think that actually worked in my favor, because as you know, and partly what we're going to discuss today, is it's all right doing implants. If you can't do the restorative, forget about it, because you're just gonna end up with problems, basically. So I think what we've done is we've briefly spoken already, and we've said that this may actually end up being a two-part podcast for us. So I think the best thing that we can do is probably just jump straight into it. And I wanted to hand over to you, because I know that we've discussed that we've got a few things that we want to cover. And I think what I'll do now is I'll hand over to you so that you can make a start, so that we can start to discuss occlusion relating to implants.
Yeah, I mean, for me, it's sort of biology has always, both physiology and biology has always dictated my decision-making process. For something to, nestle in my brain, I've got to understand the biology behind it. And I think that sort of sits with you as well, because I know from what I've read, both your posts and the way you talk about things, it's always been, on groups as well, it's always been, grounded in basic biology, knowing it in great detail. So when I look at occlusion, I look at both teeth and I look at the differences in implants. There was a great table that showed, the sort of subtle differences between, they weren't subtle differences, but key differences between teeth and implants. Once I understood that started to help me decide what decision-making process I'm going to use implementing occlusion with regards to teeth and implants. That was one thing. Number 2 was looking at the patient as a whole. because there is no solid guidance, evidence-based guidance on occlusion in implants. There's recommendations, there's guidelines, there's the ITI guidelines by Charlotte Stillwell, but they aren't steeped in any real evidence base. The studies on occlusion and implants, majority of animal-based studies. There are a couple of human studies, but they only show static loading. They don't show progressive loading. So we know from my understanding, and you may have read some of the papers that may always help. We try and provide a protocol, but actually you've got to look at the biology, and then you've got to look at the patient as well.
Yeah, I think with regards to that, if you don't mind me just interjecting briefly, is you're absolutely right. It's the static occlusion is easy to plan. What's hard to plan is the dynamic occlusion, and I look at dynamic occlusion in two ways. It's the function, plus it's what happens over a longer time frame, because teeth wear. And the restoratives on the implants don't wear necessarily at the same rate as what teeth do. So whatever you plan now is actually going to change over the longer time frame. So I do agree with you on that. It can be quite difficult to plan long term for these cases, but obviously that's why we're here to learn more from you.
Yeah, but I think when we look at function with patients that have implants, anyway, their movements are generally erratic and poorly controlled. So for me, the key papers by Svensson and Gregorius, these papers, they showed clearly, quite a difference in function in patients that, we give full arch to. I recently did a case using ModJaw, and we've immediately loaded the patient, and now he's been in immediate loads for 6 months, so he's now ready for his definitives. So I ModJawed him just to look at his function, and his movements were very vertical, very little horizontal. Now that could be also, his central pattern generators, his movements have become restricted because he had problems before with his teeth, so he naturally guarded, and then giving him implants, we really haven't changed much. But it is interesting that when we look at movement, patients generally restrict the movement. Now, what I have noticed is that there are a small cohort of patients that don't. You give them implants and they still parafunction, and they literally destroy your work. They're the patients you want to spot quite early on in your diagnosis and assessment, because for those patients, I would design them differently. I would look at maybe an implant overdenture, for example, on a bar, and that way I could give them during the day an implant, a bar retained prosthesis, and then at night I can give them a stabilization splint on a bar potentially, or even just a soft bite guard, depending on the requirements of the patient. There are different designs for different patients. I mean, I think if we just sort of go back a bit and just start right at the basics, just so the guys listening can sort of, build a journey for them. For me, the key sort of differences between implants and teeth are, one, the modulus of elasticity between titanium and bone. So it's vastly different. I mean, we can talk about collagen, fibril, orientation and all that sort of thing, but actually the biggest thing for me is the modulus of elasticity difference between titanium and bone. Whereas dentine and, root dentine is the same as bone. When you apply force, the fulcrum is the apex. But in implants, when you apply excessive force, the forces are concentrated around the crest. So it's that principle for me is, I know biology will focus the force in the crestal region when it is on implants, whereas on teeth, it sort of goes to the apex and it can cause mobility. So from a static perspective, my process is I give them a static occlusion that I would give them, that I would give for dentate teeth. And I would only make it 20 microns lighter, and then dynamic I prefer group function. So I prefer to give them shared guidance, both in natural teeth rather than canine guidance, for example.
Yeah, I'd agree with everything that you've said there, and that's the same as what we aim to achieve at Evo as well. So when we're doing our full arch work, our aim is to go for group function. Purely and simply because there is no give in these prostheses, and like you said, it's that forced concentration that happens. So when you're going through natural teeth, you have that little bit of play in the PDL, which will actually, it will act as a shock absorber and give you that little bit of breathing space, whereas that's not the case with full arch prosthetics on implants. So you need to share that load as opposed to concentrate it in one area.
Yeah, absolutely. I mean, just from a mechanical perspective, that makes sense. But that's your full arch case. But what about single unit cases in a dentate arch? How do you design the occlusion both in static and dynamic? Number one. Number two, how do you communicate that to the lab? Because there's a lab side that needs to make sure they're doing the same as you. Otherwise, you get a crown back. And if they've not tightened the screw to the same torque, and then there's also issues there because, each time they use an old lab screw, it's not giving the same torque. So there's actually a lot of factors that we need to sort of address through the journey of the patient, just even for a single crown.
Yeah.
The full arch cases are more challenging. But you first got to, we've got to nail how they can do a single crown, for example. So I'll sort of share with you how I do things.
Fantastic. Just about to ask, would you share how you do things? Purely and simply because you're absolutely right from a lab perspective. Quite often they get a set of impressions and it's like, can you make a crown? It's this implant system. And I'm not going to go into it in too much in detail on this podcast because I've got others with regards to this. But I order new lab screws, new prosthetic screws for each and every case. And there is a reason for that. And it's, as you quite rightly said, is components get worn. If you're reusing things, and particularly when it comes to tightening things down, if you're using the same screw that your lab used, the screw's strained and stressed already. You haven't got control right from the start, and you're inviting problems. So if you could go over your lab process, that I'd love to hear that. That would be fantastic.
Yeah, and for me, the rule, I just keep it simple. One piece of articulating paper. It's the AccuFilm 20 micron. And what I do is, initially, I used to use two pieces of articulating paper. One was 40 micron and one would be 20 micron. And what I would get my lab technician to do is make sure he has a new sort of prosthetic screw, a new lab screw, and obviously a new analog. So he's not using old analogs. He's using, for each case, there's a new process. He will tighten the screw retained crown. Let's assume it's a screw retained one. He will tighten that down to the required torque for that implant system. So I use Astra EV. It's 25 newtons. So it's straightforward. And then he will do any adjustments to the occlusion based on making sure that there's no contact at 20 microns, but there is contact at 40 microns. So I try and make sure that the crown is only 20 microns infra-occluded. So he does that so that when I then get it back, I can then screw it down to that 25 newtons. And then really there's probably a minimal amount of adjustment required. But I don't do shim stock hold. I don't fold it because for me, that's too predictable. I don't do the clenching test because if you get them to clench, you only have that one opportunity to clench and it takes 30 minutes for the tooth to come back to its original height. So I don't do the clenching test because it doesn't make sense to me. I just basically do 20 micron lighter. I make sure the lab does the same. And I make sure there's contact at 40 microns in static. So I use one film and I fold it for 40 and I keep it single for 20.
Yeah.
And that's and that's it. And so I give them a contact at 40 microns, but not at 20. So it's 20, in my head, it's 20 microns light. Now, there is some issues with that, but there is some issues with that. It's got to be watched, because as you know, when you tighten the screw down and you have that preload, then over time, several things happen. One, you start to get unscrewing very subtly. So the crown will start to automatically become super occluded anyway. And you're all going to have some adjacent wear of the teeth. So every year I just do the quick test, 20 micron heavy. If it is, I just adjust it a little bit, and I always keep it 20 microns lighter through the journey of the patient.
So how does your process start to change as you move away from single units towards bridges?
So same process. If I've got adjacent teeth either side of a bridge, then it's straightforward. But I actually like to give full contacts as if I was giving them teeth. So I assess the patient on their awareness. And if the patient certainly, for me, if the patient is hypervigilant, for example, they are getting full occlusion like it was teeth. So it'll be 20 micron contact on all the teeth, even if it's implants. If that's sort of the rule for bigger bridges, so 3-4 units, I actually want them to have proprioception from their opposing teeth. So I keep it as if I would be doing it like dentate patients. I don't do it infra-occluded if I'm doing bigger cases. So yeah, as I was saying, what is important for patients is that they do have some proprioception from the opposing teeth. If they don't, then some patients react. And I have seen it. I've got cases that show it. I've seen cases where the patient's been super occluded from implants and they've reacted to that. And the natural dentition was occluding against it. So I gave them the same occlusion that I would give them if it was a conventional bridge on teeth. I mean, what I've seen is that if you give a patient infra-occluded occlusion for bigger prosthesis, what I find is that they do react. And the other thing is, I've seen it on the flip side. You've given super occlusion on implant crowns, and they've reacted.
To be honest, I hadn't thought about that as much as what you're describing with the designing the crowns in infra occlusion and checking it on a yearly basis. Obviously, I mean, my protocol so far has been to build it into occlusion, but make sure in all excursive movements that there is that there's no contact. But obviously, reflecting on what you've just said with regards to you do get that loss of preload and adjacent wear of the adjacent teeth. I mean, that makes perfectly sense. So that's something that I'm going to start immediately doing is checking. Is obviously altering my lab protocols, but checking on a yearly basis as well.
I mean, I can show cases on it. That's why I've seen it. I've actually just documented one case which I've recorded over sort of 3 or 4 years, and it's the same thing every year they come in. It's heavy and it's touching at 20 microns. So I just basically adjust it a little bit, and it's touching at 40 microns. So I just keep it, and it's now 4 years, and there's no issue. The bone levels look great. I'm not saying that the bone levels are, always necessarily related to occlusion, because there's so many other factors, but at least I can sort of eliminate occlusion as one of the causes if a complication arises.
So with this protocol, are you finding fewer prosthetic complications as well, such as screw loosening, abutment fractures?
Yeah, I mean, I don't want to touch fate, and I don't want to tempt fate as well. I haven't had one yet, and I've been placing. I mean, I can't remember the last time I've had a. Yeah. The only I used an Ostem implant for the first time, and I did a cantilever bridge off it, and I gave sort of group function, and that one it's an internal hex, so it's not a Morse taper, so it's sort of that does come loose every sort of 18 months. So it does sort of make me think, with the Morse taper and the connection with Astra EV, I very rarely have a restorative issue. Certainly single crowns and bridges.
Yeah. And just in case there's anybody listening who doesn't quite understand the term Morse taper, it means the connection between the abutment and the implant itself. The taper of that connection is quite narrow. So when it all gets prosthetically screwed together, you effectively have a cold weld of the metals. So it's that cold weld. The studies that I've seen from it allows you to place the implant subcrestal, and with certain implants you can go 2-3 millimeters subcrestal, and you get very stable bone levels, and it's because of that cold weld. So that's just for anybody who's listening who doesn't quite understand the term Morse taper, but obviously I appreciate there are probably those who do as well. So
yeah.
Okay. So with regards to parafunction and bruxism, what are the things that you're looking out for then? Because obviously, we've had some discussions on this in the past, and my treatment towards parafunction, I look at it from a very simplistic point of view. But my main thing that I'm looking for is I'm looking to see the wear facets and how things fit together and how dynamically everything's moving, because that tells me kind of like what the patient is doing. It goes back to that dynamic assessment that we were talking about. So if you wouldn't mind talking through what you do with parafunctioning patients and how it may alter your treatment plans.
So yeah, I think the assessment for me is really quite important. So parafunctioning patients, I'm intrigued, what is causing the parafunction. So I'll look more, it's the sleep analysis. I will also look at any sort of active signs of parafunction. So, cheek ridging, tongue scalloping. With cases that patients have failed dentition, it's obvious if a patient comes in with severe tooth wear that they're going to parafunction on your implants. It's the ones that are a bit more difficult are the ones that come in with perio, and they're not parafunctioning because the teeth are loose. So you'll do I'll do a TMD analysis to make sure that there's no joint issues, muscle issues. I'm looking for mesenteric hypertrophy. I'm looking for and with the sleep analysis, we do a sleep Ohip Score, plus I look at their BMI, I look at them as a whole, because if I suspect that there is a sleep apnea relation, then again, giving them implants, fixed teeth, and they start parafunctioning, it's just a recipe for problems later on. So I think we've got to first accept that parafunctioning patients, they are not as straightforward to manage as a patient who doesn't parafunction. And it's multifactorial, the causes of it. And what we're trying to do in our assessment is spot those patients. What if I spot a patient that parafunctions, I am reluctant to give them fixed teeth. Or I'm looking at redesigning the dual arches and maybe making one on a bar and maybe the other on fixed. But also I may think about a different material as well. I won't have zirconia against zirconia, for example. I'll want to have some form of...
Yeah, that's definitely a recipe for disaster.
Yeah, and I think it's just, once you've assessed it, once you've spotted the patient, you're probably the same as me. Patients come to you when they've had full arches go wrong, shattered porcelain, broken restorative components. And you're looking at it and you're going, I would have done that differently anyway at that point. But, we know now we need to design their system differently. My preference with these patients is ideally a bar retained prosthesis as an ideal, because I like the fact that I can detach it. I like the fact that we have a little bit of protection between both elements, but also we still get the improvement in quality of life. The patient still has the sensation of a fixed prosthesis, but we've got an additional protective element involved. So that's sort of my go-to.
Yeah, I think one thing you touched on there, which is really interesting, and it's quite often overlooked because it's not really taught at undergraduate level, is the sleep quality and sleep apnea. And I don't know about you, Riaz, but what I've noticed is my patients who are coming in. What I'm noticing is over the years, generally, systemically, they seem to be getting sicker, whether it's stress or poor quality diet, which is having a knock-on effect on their overall health. You know, we know that stress increases parafunction, but people are getting sicker, they're getting more overweight, which is increasing sleep apnea. And what we've noticed is there has been a drop in bone quality, particularly mineral density of patients who are coming in. Now, again, this is a bit beyond this podcast, but I will be doing one later on the number of factors which are involved in bone mineral density. Is, you're talking about gut bacteria, you're talking about psychological stress, you're talking about vitamin D, you're talking omeprazole. I just wanted to ask you, are you noticing the same trend as well, that people are coming in needing this complex work, but they're coming in more systemically disabled and harder to treat?
Yeah, I'm not just with implant patients. I'm seeing that trend with our normal dentate patients. I think when you are stressed, your body reacts to that stress and generally needs some form of energy supply. I think our decision-making process at the point when we're stressed generally tends to be a poor decision. We tend to take high carbohydrate gain or high sort of sugar gain to give us that feeling of improved, endorphin release, to try and counter obviously the cortisol and the stress. But then, when your gut bacteria are poorly fed, then that ultimately has an effect on sleep quality. There's the Australian group, I've forgotten the name of the author. They've shown consistently now that gut health and sleep are intimately related. Now, if you're not getting enough good quality, stage 3 or stage 4 sleep, and you're staying more within stage 1, stage 2, and having REM, then it's in stage 1 and 2 that we tend to parafunction. So it's, Lobizo has shown, through his literature, stage 1, stage 2, that's when we parafunction. If we don't get enough good quality stage 3 and 4 sleep, then we're going to parafunction more. Now, if you're not breaking your food down properly and not having the nutrition, so let's go back to, not stress, but just actually a clinical disability with teeth. They're not eating breaking their food properly. Is that also potentially causing an effect on gut health, our gut microbiota change, and then we that has an effect on our sleep. We then potentially parafunction more. So it is a vicious circle. But I think us as sort of health professionals, we do need to be looking at the overall health of our patients, not just physical, but emotional and psychological health. We need to be assessing all elements of them, because it's for me, we can restore teeth, but do we rehabilitate our patients? That's what I want to know.
Yeah, sorry, mate. I was just going to say, based on that, one thing that we regularly do is we do the Ohip Score, which is a sequence of questions based around the patient's psychology and how their teeth is currently affecting their life. And the reason why that's important is it is a psychological assessment, and this is used quite, as you know, this is used quite a lot in studies where we're doing major restorative work for patients. And one of the reasons why we do it is so that we can see which patients have a severe disability that we're more likely to be able to help versus those who are just coming in just on the off chance, I just fancy having something done, but it's not really impacting their lifestyle that much. And those are the patients that we want to be careful of, purely from a point of view is if it's not really if affecting their life that much, and they have major treatment done, they're more prone to pick up things on the minor things that go wrong. Because I'm like, well, I didn't have this problem before. So I agree with you that psychological assessment is very, very important, and it's great to hear somebody else talking about it as well.
Yeah, I mean the quality of life, the quality of health and life related statistics, they're crucial, but it's still subjective. When we think about occlusion, everything that we do is subjective, and I don't like that. I like occlusion to be subjective. I like occlusion to be objective. I want to be able to record an improvement. So, for example, my sort of process is, I look at EMG data. So I have an EMG machine. I look at module. I look at functional data. And I also look at, sort of using the T-scan, I look at force data. So I can measure objectively what the occlusion is like. That's, for me, is quite important. And then you've got to marry that up with your subjective scores, which comes from the Ohip, which I think really is very important as well. And that way you have a real overarching sort of understanding of your patient, both from a subjective perspective, but also an objective. And I think also the objective data helps the patient just as much. If you show them, look, this is your muscle data at the start, look at your muscle data now, we've got an improvement. That's really uplifting for the patient, because they already felt it, but you've actually measured it. You've actually said, look, there's your impact data on your muscle, for example. It was, it's 60%. You're well below the threshold. But now, look, we've got your muscle activity to 80, 90%. That's fantastic. That is an objective improvement. And then you marry it up with their Ohip scores. Wow. That's actually my PhD at the moment, but it's on DAL. It's looking at both Ohip data, their subjective analysis of their teeth before and after, but also, an objective analysis for, both contacts, both digital, analog, looking at how their contacts come together, looking at their muscle data, looking at their functional data. These are all sort of objective measurements.
And actually, based upon what you just said, is obviously there's a big shift nowadays towards digital everything. People are moving towards digital articulators, digital scanners. Could I get your thoughts on where we currently are? Is the technology there? Is it good enough, or is it actually better than analog, or do they both still have a role? What are your thoughts?
For me, this may sound harsh, but analog is dead. It's over. Digital is now. Yeah. I mean, but it's not. Digital articulators. You've got to understand how the lab are using your digital articulator. How are they positioning the model without a face bow? Now, I know IDDA, for example, have a digital face bow to help you position the models. So there are tools out there, but a digital articulator doesn't replicate lateral movement. The condyle, for example, of the articulator is a ball.
Yeah.
But our condyles are potatoes. Where they're not the same. So we're trying to use a device that gives us inside out movements, but our patients are outside in movements. So I prefer the module. I think with the module functional, it's a 4-dimensional 4D tracker. I think that for me is now, the gold standard for what I do. But there is people like Javier Vasquez who does it with PsyCap function, and he is, he's at a crazy level. But I find with the module, my muscle data and my T-scan data, I am far more accurate, far more objective with my occlusion. It's not how are you feeling, Mr. Smith? Does that feel good? Yeah, that feels good. Okay, off you go. That was our baseline score with patient endorsement, then it's good.
Yeah. What's the learning curve on these like?
Oh man, I mean, you know what? You're a geek like me, so let's be honest. You're gonna love it. It's not a learning curve. It's a journey, and it's a journey of discovery. And yeah, I love it. I love what I tend to do, and this is again probably the geek in me. I do my pre-data, so I both do mod-jaw, functional data, T-scan data all before. Then I used to do it in provisionals, but what I realized in provisionals was the patients were guarding themselves because they knew they were in prototypes. So they wouldn't chew the same way. They would narrow their function. They would apply less force because subconsciously they knew the material was soft and it felt soft.
Yes.
But once I put them into the definitives, the motion changed, so I could show both pre-data, how they started, and an improvement certainly in functional movement, muscles, and force management. And what was interesting was there was a case that I did, and I did the mod-jaw before, and I did the mod-jaw after, and his jaw motion at the start was not too bad, but when I put him into his finals, on his on his left side, his chewing motion really narrowed, became very vertical. So I started to look at what was causing that, and there was a non-working side that I'd introduced. So when he was chewing on the left, he was hitting this right palatal cusp, upper six. And when I asked him, when he came in, I said, how you doing? How's everything? He was like, I love it. Aesthetically looks stunning. I'm really happy. But, he didn't mention function. He never said, I feel like my chewing is narrowed on the left side. It's only when I looked at the motion and the data and then I, photographed it and recorded it and then I adjusted it. I was like, wow, okay, there you go.
I mean, this is new to me, and this is so far beyond what I've heard previously, because you've actually got data showing how the patient's jaw moves, and you can demonstrate a difference in movement when the patient's in provisionals versus when they're in their definitive restoration. And based upon that data is you're really starting to narrow down on the minutiae of issues which may cause long-term problems, and you're managing to intervene, intercept, and deal with them before it becomes an issue. Is that right?
Yeah, I'm still early on. So in the next, I think by September, I'll have my first case where I've done, pre, post, and 1 year motion data to see how they've actually adapted to the definitive restorations after the year. And I want to look at that. I want to look at that data and go, now, that's a big discussion, because if the patient's going through a divorce at the time, the jaw motion may change, not because going to do with the teeth, it's going to be to do with the psychological state of the patient. So that's why I've started to introduce the Ohip scores within it, seeing where the patient is, as well as not just looking at the occlusion. Where are they in life, from a psychological perspective? Is life good? If life isn't good, then it's good to know that, because it'd be interesting to see if their jaw motion changes when things are not good. I've shown it on a case with articulating paper. I did an upper arch rehabilitation. It was a upper arch and a lower posterior rehab. The only teeth I didn't prep, the lower 3-3. And I recorded the occlusion, both static and dynamic. At the time, I fitted the restoration. So I had good static and I had group function in dynamic. And then I left the practice. I wasn't working there anymore. And then she sort of finds me about 4 years later. She comes in and she's got TMD issues. She says, I woke up this one morning and I've got pain. And I've been in pain for about a month now. So I looked at the occlusal contacts at that point, and all her contacts were heavy anterior, no posterior contacts, and a guidance had all moved on to the pontics that I'd done on the bridge. So she had no group function, just guidance on the pontics. And so I didn't make any adjustment. I just made her a splint, to treat the sort of the myofascial pain, with the other processes that we do. But I made her a splint, and then I recorded the occlusion after the splint therapy, and the occlusal contacts were the same as it was, 5 years ago, 4 years ago. And so that, in my mind, was like, look, that just shows you how muscles change the contacts. If you treat the muscles, then you're going to have a more comfortable or a more reproducible position. Now, it will change because life changes, and teeth wear and periodontal ligaments move and so on. But at least you won't have a major difference. It's more reproducible and more stable.
Yeah. I was just going to say, I mean, that's obviously a good discussion to have with patients as well. And obviously, the more complex the treatment you're doing for them, I mean, whether it's on implants or not, but, is then your part of your informed consent can be, is your mouth, your bite, even how you chew will change based upon the stresses that you're going through in life. And as you were saying, that if you can actually track the jaw movements and during different phases of their life and relate it to an Ohip score, that that is comprehensive, holistic patient care as it should be done. So I definitely want to learn more about that, because that just sounds absolutely fascinating. I think particularly if we're doing big cases, that is very, very impressive stuff.
No, thank you. I mean, it is early on now, and it's so interesting. I think for me personally, sort of on my journey, you try and be a jack of all trades, I suppose, because I suppose life dictates that to a point. I always wanted to be good at everything, pros-wise, dentures and so on. But I sort of slowly just realized, actually, TMD occlusion, that is something that I love, I'm very passionate about. And I'm just spending more time now, looking at the causes and treating patients more sort of from a bigger perspective. Certainly Ohip, I mean, we do the stop bang analysis. We do a lot more than we would do than most people, because for me, what's important is I'm treating the patient as a whole. I mean, what's interesting in a conversation with patients you have, we do talk about life in general, and I try and get my message across, but I tend to do it more in a sort of a jovial way, sort of, for example, cars as an example. I say, look, at the end of the day, your implants are a mechanical replacement for teeth, just like a car is a mechanical replacement for walking. It replaces one of the functions. Now, how you respect that, how you monitor that, how you service that means that you're going to get wear and tear. But I do try and stress the caveat that the car they only use 2 or 3 times a day, if that. Their teeth they're using, 10 times, 20 times more. So they need to be more respectful of what we put in their mouth than they would be of that car. I will joke, about it. So you've got a Ferrari now. You've got to maintain this Ferrari, And so that way you're sort of planting seeds in their mind that this is something that has to be respected. And that's probably my favorite word when it comes to patients. I say, look, you just need to respect the work that we've done and what's in your mouth, like you would respect that Ferrari that you've just bought. You'd polish it, you'd clean it, but you've got the maintenance of it as well. And that's what they need to know.
You take it for service as is required.
And what's the irony of it is when as soon as they have their teeth fixed, they walk out the door. They don't even look after it. Some of them, they just, they don't look after it. They don't care for it. And then they come back and they go, you've given me a dud implant. Like, no, you take the car out of the showroom, you crash, bang, wallop it against the curbs and stuff. That's beyond wear and tear. So I do try and make sure they understand that.
Yeah. So for those wondering why we've all of a sudden had a change in lighting and why my position's changed, is because I dropped connectivity the other day when we were chatting. And so this is a different day, completely different time, and I'm sat next to the internet writer. So hopefully we can get the last little bit of information. So Riaz, we were chatting, mate, about the mod jaw and how you checking dynamically the occlusion and how it helps with your cases that you've noticed that patients will change their chewing patterns based upon whether they even know whether they're in provisionals and or definitive restorations. And we were then starting to talk a little bit about maintenance of these people long term. And I think the phrase that you use is when you say to your patients, look, it's your responsibility to look after this. This is Ferrari level work. You would go to service a Ferrari. You got to come and have this serviced as well. So for those listening, would you mind going over what your protocol is for maintenance of larger cases? Because we have touched on maintenance of single implants. So for larger cases that you're more concerned about, what would be your protocol?
So if it's an immediate load full arch case, then what I would do is give them a very sort of a protected, well, what I noticed straight away with patients that are immediate full load cases, you give them the same guidelines that you would give, be careful, no hard food, all the, cleaning and all that sort of protocol. What I did with those patients, I've started to do a mod jaw on them. And after when the implants have healed and we've got integration, what their chewing is very vertical. So they basically have very little lateral movement. And that was because I feel that we've given them not a locked-in occlusion, but we've given them an occlusion which is purely statically driven, not dynamically driven. So what we're doing at the moment is we're test running, adjusting those provisionals to try and give a more dynamic movement and see if that improves through the sort of additional last 2 months of that. So around month 4 of healing, we're doing occlusal sort of equilibration and trying to give them group function. It's a shallower guidance. So if I was to show pictures of how I do direct definitive restorations on teeth, I try and, I'm looking to see them shaped like teeth. The cuspal angles and so on are like a normal premolar, normal molar, and so on. Whereas what we're giving them is a very similar occlusion that we get when we do an articulator, which is quite shallow cusp angles. The canine sort of palatal angle is the same as the incline, the sort of the palatal incline of the buccal cusps. So you're sort of following a pattern that it makes it work in group function.
Yes.
The key as well is obviously diagnosis prehand, because, if that patient, what worries me, and I had a case only yesterday, gentleman sort of destroyed his natural teeth. They then done endo post crowns and he's going, I want implants. And I'm going, and that's going to be an interesting one. He goes, and I want fixed. And I'm going,
even more interesting.
Even more interesting. I've got to write your letter today, and that's why I'm up this morning. I'm going, I've got to write his letter today, and it's thinking, there's caveats there. He's going to have to, wear a guard, some form of guard post-operatively, with the caveat that if he doesn't, he's going to destroy the teeth. And I need to make sure that I design when he's in prototypes, he is the one that I need to give, a lot of protected occlusion. So sharing the forces is the objective, both in my finals. So once I'm into my finals, I'm looking at group function. Now, if you're going to use a choice of material, if you're using zirconia, I personally don't like zirconia in full arch fixed cases. For me, I think it's just too harder material. It's too brittle, and the occlusion is very difficult to design in zirconia. It looks amazing, but actually it's glass, and glass, when you put oblique forces on it, it's very fragile. You put compressive forces on it, it's super strong. So zirconia can handle the compressive forces of swallowing, but not really erratic movements of chewing.
Yeah. And I think a big mistake a lot of people make with zirconia as well is they don't understand the material particularly well. Because when it first came out, there was these YouTube videos of it being smashed with a sledgehammer, and there was no damage done to it. In fact, it damaged the desk. I think what people don't realize with zirconia is, yes, it does have crack deflection properties, but those crack deflection properties will actually deplete over time, normally over a period of about 4 or 5 years. And those crack deflection properties will reduce faster in a bruxist and in a warm, moist environment. So when people start saying, "Oh, I'm doing monolithic zirconia bridges," it's been fine for 2 years, and I turn around and say to them, "Of course, it's going to be fine for 2 years. It's the 5-year mark we need to worry about." And I've got another prosthodontic friend in America, Prof. Lane Ochi, and he's of the same opinion as well. He does not use zirconia in full arch implants. He said it for the same reasons. He said it's going to fracture at some point. He said, I would prefer to use something that has got the chance of a much longer time frame.
Yeah, no, I agree. I think Mark Northover, who's done a lot of sort of these zirconia bridges, so we're looking interesting. I mean, he might be doing a PhD project on it as well. I don't know if he is. He's talking about it, but it's sort of, he's got retrospectively, I can't remember how many zirconia full arch bridges he's done, and they have fractured. He has had a couple that are fractured, so it is interesting, to see, what occlusion they provide, and can it work in a mouth? I think it can work in a mouth where the patient is a very, very vertical chewer, a very sort of protected chewer. That's always been my thing. Do we restore or do we rehabilitate? I don't know if you know Francesca Valetti. She was talking about this as well a couple of years ago. She was the one that got me thinking on that restore versus rehabilitation. How do we know we've simply restored the patient back to their, original chewing function? Otherwise, we've not really delivered what we meant to do. It's interesting. Implants, I think once you recognize that biologically implants cannot handle the same occlusal forces. Yes, there was a recent sort of Facebook post, I think it was by Lucas, and he showed the clip of implant occlusion. It was really funny. I don't know if you saw it. And he'd taken a cropped picture of the Carl Misch's paper. They put the guidance for occlusion in implants. And there was a table, and most of the points were valid. They were all designed to be protective, shallow cusp angles, all that sort of thing. It was like, fine. And then it came to single implants, and it said something along the lines of, let me read it out, because I sort of, it was a debate that me and him had. And it went along the lines of sort of, he said, let me just quickly, I'll read it back, because it was quite interesting how we, and I said, we were sort of, it was an open debate, nothing sort of critical at all. It was just, he put it on there, and I thought, that's right. So he'd sort of put it on a post. It was, and one of the sort of the points was, light contact. This is for single implants. Light contact, heavy bite, and no contact at light bite. So I know Lucas is very precise, but that statement is so imprecise. It's so subjective. What is that? So I sort of said, all logical points except that one point. So he responded, he said, tooth holds 8 microns shim stock with light bite and heavy bite, but crown on implant, this is on teeth. So tooth holds 8 microns shim stock with light bite and heavy bite, but crown on implant holds with heavy bite only. So I said, well, this isn't reproducible consistently. ITI guidelines state, sort of 30 microns lighter. And so he was going, why 30? And I just joked, best asking them. There's no evidence-based guidelines. We got back to sort of, he said, I guess they prefer to be more safe. We want to exclude the implant for the amount that is equal to initial tooth movement. So between 8 to 30 microns. But as you know, the thinner the paper, the more precision and so on. And I said, those skills that you have, there's too many errors through the casting, through the preload when screwing, through unscrewing, through, you only have that heavy bite clench. You only have one go at it. Yeah. As soon as the patient clenches once, the teeth go into the periodontal ligament. It takes 30 minutes, anything up to 30 minutes, before the teeth come back to that position. How can you test that heavy bite once?
Book them in all day.
Yeah, I mean, that's sort of you just can't it's not reproducible. So anyway, it sort of stopped at that last point, but the issue was funny. It was just, that was just something that we were discussing, and they were sort of Carl Misch's guidelines from 10 years ago. I think it was 2011. Yeah. I do recommend that document is quite a good document on implant occlusion. The only issue for me is in static. So for me, if a single implants, I give them just a dentate occlusion. And a patient who's power functioning, I can try and give them 20, rule of thumb for me is no touching at 20 microns, touching at 40. And it's just simple. And then guidance, dynamic guidance is shared group function all the time. I don't give canine guidance on a canine implant, for example.
Yes.
I just give them group function.
Yeah, it's. I've already spoken to my lab and told them I want no contact at 20 microns and contact at 40 microns. And my lab technician was like, "Yeah, fine, not a problem, but explain to me why." And I said to him, "Look, there's a podcast coming out." I said, "Once it's out, I'll send it to you." So it's I've already communicated that to my lab. So it's I think
it's easier, isn't it? I mean, they've got it, but the thing is, they're doing the right thing with you already. New screws. He's got to talk it down to your talk. What are you talking it down to? You're going to still have some soft tissue issues when you're sort of talking it down, because you get some resistance that you don't get in the model. So that's why it's still sort of, things that we can't control that are in the mouth, that, the model, the mouth is a warm environment. You're going to get some degree of expansion of the crown and the metal underneath it. It's very slight. There's, if we're talking 8 micron precision, how much does that crown expand in the mouth? Does anyone measure it?
I mean, this is the thing. It's about having control over what we can control, and understanding the other factors that we don't have control over. And it's about trying to tip the balance in our favor. And this is how I explain it to my implant patients as well. So when I cover their risk factors, I say, look, we don't have control over this and this, but we do have control over this and this. So I need for you to start doing X, Y, Z to tip the balance in our favor. And they understand it when you put it simply like that.
Yeah, absolutely. I mean, I think the biggest problem we have with patients is not their lack of understanding; it's our lack of explaining. And if we shift the responsibility onto ourselves, we think of innovative ways of trying to get a point across. Even with regards to certain risk factors that you can give them an endless list, but I can say, look, I think I say, look, do you know what it smells like? Do you know what New York smells like in summer? I said, have you ever sort of stood on Hudson River and smelt what it smells like to be in New York? And they go, no. And I go, okay, I can tell you what that smells like. I can tell you what it looks like. I can tell you all that. I can get you to visualize it. But unless you go there and actually have that experience for yourself, it will be a totally different experience for you than it was for me. I said, that's the thing with risks. I can tell you everything, swelling, bruising, pain, but ultimately your experience of that will be different to the other patients that have had all those things. So, how you react to things is unique. And they get it. They sort of have, you do always joke about, I'm blessed. I have a good relationship with most of my patients, not all of them, but most.
I really appreciate you coming back on early in the morning. I think we're going to have to wrap it up because we could talk about this literally hours and hours and hours on end. So just a quick question on behalf of anybody listening is if they wanted to learn more about mod jaw and your treatment philosophies on occlusion, what would be the best approach? How could they start learning this stuff? And for clarification, for anybody listening, I've already approached Riaz and I've said to him, look, I need to learn more. So hopefully I'll be learning from him in the future as well. And that was just after a 45-minute chat. You really opened my eyes, and I'm hoping that, other people I want to learn more as well. So if you've got a couple of minutes, if you could just explain that'd be great.
Yeah, no, thank you for that. Yes, so the way I try and sort of teach occlusion is a foundation and advanced level. So it's a 2-day sort of foundation course based around the philosophy of looking at TMJ muscles and making sure they are healthy. And so that sort of bases it on TMD and then conformative occlusion. So how to just conform with a composite, single crown, and sort of the basic sort of restorative principles. The mod jaw for me is sort of an advanced level because you need to buy that equipment if you really want to learn about the digital aspect. And that's sort of done separately. I use the module for teaching because, when I say group function, people sort of see it on a static model with the markings of occlusal paper. But actually, when you show them that when the patient chews, this is what we mean by group function, you can replicate, you can see it's a visual aid. I find it a much more effective visual aid for teaching occlusion. Yeah. And then the advanced course is about increasing OVD, how to reorganize, and that's a 2-day course as well. It's for sort of small groups, so it's sort of a group of 9, and we run it in the clinic because that way we split you into groups of 3 and you basically alternate each other. And it's 3, we've got 3 surgeries in the clinic, so you basically 9 people, and I can sort of give a more focused level of attention on all 9 of you while you're doing the practical element on yourselves, analysing yourselves, doing things on each other, and so on. Yeah. Dates wise, if you look on the www.thesquaredental.com, that's the website, then it's sort of dentist section and it's the education part. It's all there. So the next dates are May, and we're slowly sort of booking up for that because I've only just opened those dates up. So we're looking, fingers crossed, if all goes well, 1st and 2nd of May for the foundation. Yeah. And then the website has all the other dates on it.
I'll put a link to the website in the podcast description, so anybody who's watching it can take a little look there. Yeah,
I'll send you the link actually, and then that way you've sort of it'll be easier for.
Brilliant.
I appreciate that. Thank you.
Yes, thank you so much for your time. So not only did you jump on with me late one evening a few days ago, we've done an early morning session as well. And I think that's just, that level of commitment to just do a podcast to helping out a mate is just hugely appreciated. So thank you so much. Thank you so much. I said I'll definitely be in touch because I certainly want to learn a lot more about this. So I hope you enjoy the rest of your day. I hope those who've been watching have gained a lot from this because I know I certainly have.